Good evening, everyone. On behalf of the Education and Professional Development Committee and the DEI Committee, I would like to welcome you to tonight's webinar entitled Where Medicine is a Mirror in Racial Inequities, Going Beyond the Sickle Cell by Drs. Rebecca Chu and Lisa Yamagishi, and Compassionate Communication, a Guide to Embrace Diversity, Equity, and Inclusion in the Workplace by Dr. Amber Johnson. My name is Dr. Shari Bird. I'm currently the chair for the Diversity, Equity, Inclusion Committee for the New York State Council of Health System Pharmacists. I'd like to provide to you now the bios of our first two speakers. So Dr. Lisa Yamagishi received her Doctor of Pharmacy degree at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences in 2017. She completed a postgraduate residency at Duquesne University, St. Barnabas Health, specializing in geriatrics in Pittsburgh, Pennsylvania. Following her postgraduate training, Dr. Yamagishi worked as a clinical pharmacist, specialized in hospice and palliative care at Delta CareRx. She's currently a clinical pharmacist in Kings County Hospital Center, where she established the opioid stewardship program. She has spoken nationally on topics focusing on pain management, opioid safety, and medical marijuana. She is an active member of the American Society of Health System Pharmacists, the American College of Clinical Pharmacy, New York City Society of Health System Pharmacists, and New York State Council of Health System Pharmacists. Our second speaker, Dr. Rebecca Chu, is currently a clinical pharmacist at New York City Health and Hospitals Kings County Hospital in Brooklyn, New York. She specializes in clinical trials and internal medicine, where she often sees patients for complex symptom management, including terminal cancer, pain, and sickle cell disease. After receiving her Doctor of Pharmacy degree from Albany College of Pharmacy and Health Sciences in 2018, Dr. Chu went on to complete a postgraduate year one residency at NYU Winthrop Hospital in Mineola, New York, where she also served as chief resident. She then completed a clinical fellowship to specialize in palliative care medicine at the James J. Peters Veterans Affairs Medical Center in Bronx, New York. Dr. Chu also has been an active member in the New York State Council of Health System Pharmacists, where she's part of the Communications Committee and has written for the New Practitioners Forum. She's been heavily involved with the New York City chapter, receiving their 2021 New Practitioner Scholarship and elected as president-elect this past June. Dr. Chu will begin her term as president for the New York City chapter in June of this year. Now some housekeeping rules. So before we get started, to share some quick points. For those that may have technical issues during the presentation, please use the chat option to communicate with us. Every effort will be made to assist in resolution. For those who have questions that you'd like to direct to the speaker, please use the question box or chat option. The CE code will be provided at the end of the program. Now I would like to have Dr. Chu, Dr. Yamagishi start their presentation.
Advance, just make sure. Hello, everyone. Sorry, we're going through, we just had to do some little troubleshooting there. My name is Dr. Lisa Yamagishi, and as stated before, I'm a clinical pharmacist at opioid stewardship at New York City Health and Hospitals and at Kings County Hospital. So I'm really excited to present this presentation today, because a lot of what we serve here within our patient population are patients with sickle cell disease. And as part of the opioid stewardship program, we closely monitor patients that are at high risk of potential opioid overdose. And patients such as patients with opioid use disorder and sickle cell patients. So without further ado, let's see. So this is just a slide to say that we have nothing to disclose. So for objectives, we are going to describe the epidemiology and pathophysiology of sickle cell disease, including the hemoglobin variants and vaso-occlusive crises. We are going to review treatment strategies and the management of acute sickle cell-related complications. We are going to lastly recognize healthcare disparities in access to specialized care, poor disease outcomes, barriers to obtain pain management, and insufficient treatment options for patients with sickle cell disease. So a little bit of background, sickle cell disease is listed in rarediseases.org as an orphan disease. However, it is the most common blood disorder in the United States, in that affects an estimated 100,000 Americans. 1 in 365 Black African-American babies are born with sickle cell disease, and 1 in 13 babies are born with sickle cell trait. The most severe form of sickle cell disease, that's sickle cell anemia, can shorten the lives of people by 20 to 30 years. So sickle cell disease is a public health issue globally. In many African countries, up to 3% of newborns may actually have the disease. And studies suggest that 50 to 90% of children born with sickle cell disease in resource-poor nations die before the age of 5. Data actually indicates that up to 16% of deaths in children younger than the age of 5 in some of these areas may be due to sickle cell disease. However, since sickle cell disease is often not diagnosed, it's rarely listed as an underlying cause of death among children. So what we find is that most of these children actually die from a typical complication of sickle cell disease, which is an infection from potentially invasive pneumococcal disease and malaria. So this is an international burden, since it can also have a domestic impact in the United States, in that many immigrants and refugees may come here from these countries where the disease is most common, but potentially undiagnosed. So sickle cell disease is an umbrella term for all mutations in the beta globin gene that precipitate the same clinical outcomes. So hemoglobin S is the abnormal form of hemoglobin that causes the red blood cells to become rigid and sickled, which is the trademark of sickle cell disease. So sickle cell anemia is caused by the beta S allele, and these patients are HBSS. And sickle cell anemia is the most common and severe form of the disease and accounts for 70% of cases. HBSC are people that inherit a gene of hemoglobin S from one parent and a gene of an abnormal hemoglobin called hemoglobin C. And that mutation actually changes the shape of the red blood cell. So while these patients may have milder anemia and less frequent complications, they can have some severe complications such as proliferative sickle cell retinopathy and osteonecrosis. There's also patients that have HBS beta thalassemia, where they again inherit a gene of hemoglobin S from one parent and a gene for beta thalassemia from another parent. And beta thalassemia is a disease that actually reduces the production of hemoglobin. So depending on mutation, there's 2 mutations. There's a beta 0 thalassemia, where these patients typically have no normal hemoglobin. And there's also beta plus thalassemia, where these patients have a low amount of normal hemoglobin. There are also less common types of sickle cell disease, and that includes HBSD, HBSE, and HBSO. And again, this happens when somebody inherits one gene from hemoglobin S from one parent and another abnormal hemoglobin, that's D, E, or O from another parent. And the severity for these vary. People with HBSD have a moderate anemia, and this is more common in patients with Asian or Latin American ancestry. When somebody inherits one gene of hemoglobin S and one gene of normal hemoglobin A, they actually have sickle cell trait. These patients typically don't have any signs of the disease, but they can pass the HBS gene to their children. However, there are some rare cases that we do see where patients may have acute pain episodes, and that's typically exacerbated by lower oxygen levels in the air, dehydration, or high altitudes. So a little bit of pathophysiology. So HBS polymerizes and forms long chains of hemoglobin when it's deoxygenated, and it distorts the red blood cell and makes it its trademark sickled shape. And these sickled cells have increased adhesion molecules that bind to the endothelial walls. Sickled cells hemolyze rapidly, and this increases the reticulocyte production, and that causes local endothelial dysfunction. So the sickled cells cause an inflammatory cascade within the endothelium, the white blood cells, and the platelets, and that causes vaso-occlusion. So the dual process of the vaso-occlusion and the endothelial dysfunction activate inflammatory responses, and this, which increases the cytokines and reactive oxygen species, and that perpetuates further vaso-occlusion. So this recurrent sickling and hemolysis combined with endovascular inflammation result in acute and chronic organ damage. The vaso-occlusion and the ischemia is primarily responsible for the acute pain, acute chest syndrome, and avascular necrosis, while the hemolysis-related endothelial dysfunction can cause stroke, pulmonary hypertension, priapism, and leg ulcers. So here's an illustration of some clinical complications that can occur in patients with sickle cell disease, the yellow being acute complications and the blue being chronic complications. Patients with sickle cell disease can suffer from acute complications that require immediate medical attention. Pain is the most common acute complication. And as individuals with sickle cell disease age, chronic complications produce organ dysfunction that can contribute to an earlier death. So the morbidity of sickle cell disease is progressive throughout a patient's life. During infancy and childhood, most complications occur in acute recurrent episodes. And because of the metabolic demands of constant hemolytic anemia, growth and puberty can be delayed. As adults, patients can suffer organ damage in addition to acute complications. Acute pain episodes, acute chest syndrome, and ischemic stroke can occur at any life stage. So we're just going to go over some acute complications that we typically see in our hospital. So acute pain episode is the most common cause of hospitalization. And we do see this a lot. It does come in waves, more so in the winter when the weather gets colder. It's a significant morbidity of patients with sickle cell disease with profound negative health-related quality of life. It's complex and poorly understood as far as the pathophysiology. We went over a few of them before, where it can cause nociceptive pain from ischemia, perfusion, injury, and inflammation. There's increased red blood cell adhesion. There's also aspects of neuropathic pain, as well as pain caused from central pain pathways. So there's no objective signs or acute laboratory findings in acute pain episodes. They're most entirely based on subjective data. Pain episodes are typically preceded by 1 to 2 day prodromal phase, which has symptoms of fatigue and diffuse body aches. The peak intensity occurs day 3 to 7. I do say that with like a huge caveat. It does differ patient by patient depending on their clinical diagnoses and underlying health conditions. Majority of acute pain events are managed at home with oral NSAIDs, or they typically can have oral opioid analgesics that are prescribed to them by their sickle cell clinician, and they have rescue doses. So according to the National Heart, Lung, and Blood Institute, patients should be evaluated for potentially other causes of pain that can be outside of vaso-occlusive crises. So typical vaso-occlusive pain crises are deep in nature, and patients will describe it as an aching sensation that is like, can almost feel like bone pain. And it's typically felt in the extremities, in the chest, and the back. Some patients, there's a large number of patients that can potentially have a stroke from sickle cell. So it's important to note if a patient has pain in their head or flank pain, which could be a sign of papillary necrosis. Abdominal pain could be several things, such as hepatic or splenic sequestration, constipation from opioid toxicity, or another hepatobiliary complication. So the key is to rapidly assess the patient within 1 hour of arrival at the emergency department and to rapidly administer analgesia within 30 minutes of triage and 60 minutes of registration. Patients should be reassessed with pain and readministered opioids if necessary until pain is under control every 15 to 30 minutes. So there's such thing as a sickle cell disease patient care plan that is recommended by various organizations. And this will be an individualized care plan that's developed by a sickle cell disease provider. And this will typically include the medications that the patient is on for sickle cell, as well as baseline hemoglobin, home analgesia doses, as well as doses of analgesia that are required to manage acute complications. So that particularly comes in handy if it is embedded into your health application. However, the way if your institution does not have a patient care plan for sickle cell disease, patients are usually managed through a thorough search of previous hospital admissions. Acute pain management should incorporate patient preferences into shared decision-making process. So usually this is done by interviewing the patient to see what typically opioid doses would manage their previous crises. So patients should continue treatment with scheduled NSAIDs. This will typically be ketorolac 15 to 30 milligrams around the clock. Calculate parenteral IV sub-Q opioid dose based on total daily short-acting opioid dose currently taken at home to manage vaso-occlusive crises. This would really depend on whether or not a patient is on chronic opioid therapy at home. But again, a thorough search of the medical records as well as ISLAB data can give a good idea of which opioids and what dose would work best for the patient. Maintain or consider escalation of the dose by 25% every 15 to 30 minutes until the pain is controlled. If a patient requires around-the-clock opioids, if your institution allows, a PCA is preferred to decrease the need for constant assessment, as well as decrease the risk of a potential overdose. Sub-anesthetic ketamine infusions can be considered for opioid-sparing strategy, as well as multimodal analgesia, which is dosed at 0.1 to 0.3 milligram per kilogram per hour with a max rate of 1 milligram per kilogram per hour. Steroids can be used when appropriate for the treatment of other medical indications such as asthma. Corticosteroid exposure, especially during cessation, has been linked to rebound pain and other complications. So the decision to use steroids for other medical indications should be made in collaboration with sickle cell disease experts. I do include the pediatric dosing of opioids here. Typically, patients that are pediatric are opioid naive, and we do use weight-based dosing, and we titrate the opioids based on patient response. So for monitoring, again, we want to reassess pain every 15 to 30 minutes until pain is controlled. Monitor for side effects, potentially include a bowel regimen prophylactically, as well as naloxone as needed for respiratory depression. Pruritus can be treated with oral antihistamine every 4 to 6 hours as needed, not prophylactically. And patients can be administered oxygen, intravenous fluids, and red blood cells as clinically indicated. So acute chest syndrome is the most common and serious complication of sickle cell disease, and it's the most common cause of death, where over 10% can be fatal. Acute chest syndrome is defined as a new infiltrate on chest imaging plus 2 of the following, which would be pleuritic chest pain, hypoxemia, tachypnea, or fever. During acute chest syndrome, microbial pathogens interact with the alveolar, epithelial, and inflammatory cells to promote the release of pro-inflammatory cytokines. And the heme released from the lysed sickled erythrocytes triggers signaling in the vascular and inflammatory cells. And the aggregates of platelets and neutrophils promote vaso-occlusion and microthrombus in the lung arterioles, and this can lead to loss of pulmonary blood flow. Fat and marrow emboli released from necrotic bones obstruct microcirculation and can stimulate further inflammation. Lung vaso-occlusion promotes ischemia, perfusion injury, failure of the blood-air barrier, infarction, alveolar flooding, and respiratory failure. Triggers of acute chest syndrome include pulmonary embolism, fluid overload, opioid narcosis, and hypoventilation. So treatment for acute chest syndrome includes supplemental oxygen with the goal SpO2 of over 95%, intravenous crystalloid infusion, pain relief, and bronchodilators for acute bronchospasm or for patients with a history of asthma. Pain relief is a careful balance in that opioid narcosis can actually cause acute chest syndrome and respiratory failure. However, not administering enough opioids can cause chest splinting, which again can cause respiratory failure as well. So the key is to be able to carefully titrate the pain regimen while trying to avoid oversedation and respiratory failure. Several case reports have described the use of inhaled nitric oxide. However, there's no randomized controlled trials, and there's currently insufficient evidence to support its routine use. Corticosteroids have been used for treatment for acute chest syndrome, but there's significant variability in their efficacy in that it's been shown to decrease the length of hospitalization. However, it's also associated with longer overall lengths of stay and higher readmission rates from rebound sickling. So the use of corticosteroids in treatment is not typically recommended for mild to moderate acute chest syndrome, with the exception of patients that have asthma. Infections should be assumed for all patients who present with acute chest syndrome. And unfortunately, there's no randomized control trials on the antibiotics that are of choice to manage acute chest syndrome. Atypical respiratory pathogens have been found in cases of acute chest syndrome, so all patients should be treated empirically for severe community-acquired pneumonia. So the antibiotic combination should always cover atypical respiratory organisms such as mycoplasma and chlamydophila. And H1N1 subtype of influenza A virus should also aggressively be treated if it's suspected as well. Blood transfusions can provide rapid and dramatic improvements in pain in patients with acute chest syndrome. Both simple and exchange transfusions can both increase oxygenation. So exchange blood transfusions can have an additional benefit by reducing the number of circulating sickle cells and preventing further vaso-occlusive events, and reducing the effect of hemolysis without increasing the blood viscosity. Not all patients with acute chest syndrome will require a blood transfusion, so the decision should be made by the sickle cell clinician. A simple top-up transfusion should be initiated in patients with symptomatic acute chest syndrome whose hemoglobin is over 1 gram per deciliter below baseline, or if a patient's oxygen requirements are increasing. An exchange transfusion is indicated for severe disease in those who continue to deteriorate after a simple transfusion. And 8 units of packed red blood cells are usually sufficient for a full exchange. So many patients may also suffer from an acute stroke. In the absence of primary stroke prevention, about 10% of patients with HBSS and HBS0 thalassemia have overt strokes, and recurrence rate is relatively high at 46 to 90%. Around 40% of children with HBSS by the time they reach the age of 14 will have a series of silent cerebral infarcts, which causes a gradual cognitive decline as the patient progresses through life. So if a patient presents with the typical presentations of stroke, such as severe headache, altered level of consciousness, seizures, speech problems, or paralysis, an urgent head CT scan should be done, followed by an MRI and MRA. Patients with sickle cell disease should have emergency red blood cell exchange transfusion with a goal with HbS reduced to less than 30% or HbA above 70% for patients with HbSC. Adult patients should receive the standard therapy for acute stroke, that's with or without thrombolytic therapy or thrombectomy if indicated, followed by red blood cell exchange. Patients should be initiated a monthly simpler exchange transfusion, and for patients that are unable to do so, should be initiated hydroxyurea. Acute anemia is another complication, typically caused by splenic sequestration crisis, as well as aplastic crisis. Splenic sequestration crisis is typically seen with rapid swelling of the spleen, thrombocytopenia, increase in reticulocyte count 25% above the baseline, or hypovolemia. Aplastic crisis may be caused by parvovirus B19 infection or an acute inflammatory illness and cause a significant decrease in the reticulocyte count from the baseline. So acute anemia is defined as a decline of over 2 grams per deciliter below the patient's baseline hemoglobin. The baseline hemoglobin varies depending on the patient's genotype, and the treatment for all cases are transfusion and to consider splenectomy due to the high recurrence rate. Other acute complications of sickle cell disease include fever, hepatobiliary complications, multi-organ failure, priapism, acute ocular conditions, as well as venous thromboembolism. Chronic complications include chronic pain, avascular necrosis, leg ulcers, ophthalmic complications, sickle retinopathy, sickle nephropathy, pulmonary hypertension, and stuttering recurrent priapism. So just want to briefly go over some disease-modifying therapies for chronic sickle cell. Commonly used one is hydroxyurea. That's considered the gold standard, is the one that's been used the longest. And it is an oral pill or liquid that is dosed once daily. We also have Oxvitra or Endari, oral, that's taken daily or twice daily. Adakveo is an infusion that is to be administered once every 4 weeks. And it's a good choice for patients who have recurrent severe symptoms. And now I'm going to turn over to Dr. Rebecca Chu, who's going to go over the barriers of care.
Thank you, Lisa, for that transition. So as Lisa mentioned earlier, sickle cell disease is an orphan disease in the United States. So that means that it affects less than 200,000 persons. Although it is prevalent worldwide. It affects about 100,000 persons in the United States. And this image shows the estimate number of persons with sickle cell disease based on the 2008 US Census population and corrected for early mortality. Most concentrated in the East. However, note that Florida and New York State are the darkest red colors, which represents greater than 7,000 people. So I think from this image, we want to also think about or question how many areas actually also have specialized sickle cell disease care centers if a disease is considered an orphan disease. Healthcare providers with comprehensive expertise are scarce, particularly in low income and rural communities with limited resources. Furthermore, in non-specialized hospitals with few sickle cell disease patients, poor outcomes were reported, likely because of the lack of hematologists with sickle cell expertise. 75% of patients with sickle cell disease also rely on public health insurance, which offers poor reimbursement for the cost of care. Current payment models do not adequately support physicians or hospitals for the cost of providing the complex care required to treat sickle cell disease. One of the biggest barriers for sickle cell disease is pain management. Besides the physical pain that appears insurmountable, the mental and psychological pain truly threatens the well-being of patients. The pain of not being believed can tear patients down. Patients with sickle cell disease in pain and at their lowest point can find themselves being accused of trying to obtain opioids because of a drug addiction, coupled with the thought that in order to receive care, they need to clean up and dress nicely while it feels like their body is killing them from the inside. It is the pain of having to explain that labs and vital signs cannot show their pain. It is the pain of hearing the hallway conversations between doctors and nurses about quote unquote frequent flyers or patients with the disease who are angry and uncooperative. Oftentimes, these behaviors, such as requesting a specific dose of opioid or requesting that something be administered intravenously, may be normative in patients who have experienced a history of undertreatment for their pain. So in other words, sometimes in an effort to advocate for themselves, these patients are questioned or ignored or mislabeled. Stigma for people with sickle cell disease is most apparent when they're in the emergency department with severe pain and require compassionate evidence-based care. As we've already alluded to, the recommended treatment for acute sickle cell pain involves medications associated with abuse, misuse, and addiction, which further challenges the clinical decision-making. Not only are individuals with sickle cell disease already stigmatized as drug-seeking, the nationwide focus on an opioid epidemic poses a new challenge for individuals in pain. In a study of sickle cell patients and adults, 22% of deaths were associated with acute pain episodes. Also, as Lisa mentioned earlier, the National Institute of Health recommends treatment within 30 minutes of triage or 60 minutes of registration. However, these 3 studies demonstrate that the average time to receive the first opioid treatment was at least 60 minutes prior to intervention, with results of upwards to 150 minutes as seen in TAN and B in 2017. Each of these studies highlights that maybe we are not doing our best practices for sickle cell patients and that there is room for improvement. The addition of a multidisciplinary team demonstrated good effect in reducing time to treatment and accomplished goal times within 13 months. Additionally, it's also important to point out that in the Evanson study in 2016, the authors surveyed patients regarding their thoughts on ER pain care and treatment. Majority of these patients stated that they would prefer to manage their pain at home and cite negative ER experiences to be a large limiting factor. Speaking of negative experiences, I also think it's important to examine the experiences that us as healthcare providers may have. This study by Hayward in 2015 wanted to explore the extent to which clinical characteristics such as race, sex, professional discipline, and amount of exposure to sickle cell patients in pain may be associated with attitudes towards sickle cell. 276 clinicians reported their general attitudes towards patients with sickle cell disease. The attitudes were divided between negative and positive attitudes, and I have them listed here on the slide on the left. They were asked to estimate the percentage of sickle cell patients they saw from less than 5%, 6 to 20, 21 to 50, 51 to 75, or greater than 75%. The scores were summed, and the higher values represented a greater level of negative or positive feelings. For the right column, suspicion over concern raising behaviors, clinicians were asked to express their level of agreement from strongly disagree to strongly agree. These items were selected for study because they represent concerns that clinicians often have about pain management for patients with painful chronic illnesses in general, and about patients with sickle cell disease in particular. Higher scores on this measure indicated a greater endorsement of the belief that these behaviors may represent inappropriate drug seeking among sickle cell disease patients. These authors found that Asian clinicians were statistically more likely to have negative attitudes than when compared to white clinicians. The authors suggested that this may be due to cultural differences between Asian clinicians and white clinicians. They also identified that nurses had greater levels of negative attitudes about sickle cell disease when compared to other clinicians and would often think that their patients were drug seeking. So knowing that nurses tend to have more frequent and more intense exposure to patients' experiences of acute pain while in the hospital. They were more likely to bear the burden of any anger, frustration, or concern expressed by the patient because of their disease, reason for hospitalization, or any interpersonal conflict that may occur during the hospitalization. Finally, the authors also saw that clinicians with the highest level of exposure to sickle cell disease patients may have more negative attitudes. This may be due to more exposure or even a more involved level of exposure to sickle cell patients who have higher utilization, exhibit more problematic behaviors, or who may generally just be sicker than other sickle cell patients. This combination may invoke more negative attitudes from the clinicians and thoughts of drug-seeking behaviors, both of which were statistically significant. Another barrier to recognize should be the amount of patients that are being properly treated to prevent hospitalization. As we saw in the last article, there are clinicians who have these negative attitudes for frequent flyers, but how are they doing with evidence-based treatment recommendations? In a study by Cronin in 2023, it showed that we are not doing very well. This study used data that was from administrative claims databases comprised of commercial, Medicaid, and Medicare adult patients. The table above shows the FDA-approved medication utilization for all the individuals with sickle cell disease and those with an average of 2 or more pain episodes in a 12-month period. The denominators are based on eligible participants when the medications were approved. Overall, as we can see, there is great underutilization. All adults with sickle cell anemia should be at least offered treatment with hydroxyurea, and up to 63% of the individuals with sickle cell disease have at least one vaso-occlusive pain episode in a year, making them eligible for crizanlizumab, L-glutamate, or both. However, as we can see, hydroxyurea prescriptions were only seen in 25% of eligible patients. The authors did suggest that the use of hydroxyurea, L-glutamate, and crizanlizumab could vary by geographic location due to accessibility of centers to administer infusion drugs like crizanlizumab and limit access to comprehensive sickle cell care. Patients may also face challenges such as high deductibles, denied prior authorizations, and unsuccessful patient follow-up. Older patients and those who live in rural areas also had significantly lower use of medications approved for vaso-occlusive crises. It is also good to mention that a proportion of uninsured patients with sickle cell disease is higher than that of children with sickle cell disease, and these patients could not be assessed in this data, which further compounds issues related to healthcare access. But this inequity in proper medication usage does not just affect adults, it also affects our children. In September of 2022, the CDC had a telebriefing regarding data seen in children with sickle cell anemia and their risk for stroke and other complications. 3,352 children and adolescents aged 2 to 16 were with sickle cell disease and also enrolled in Medicare in 2019 were reviewed. The information was compared to the National Health, Lung, and Blood Institute's recommendations for stroke and other complication prevention. Their recommendations included annual screenings with transcranial Dopplers for stroke risk, long-term blood transfusions for those at risk for stroke, and hydroxyurea in all patients 6 months and older with sickle cell anemia to prevent complication or death. From this image, we see that fewer than half received the recommended stroke screening. The authors also demonstrated that half of the children aged 2 to 9 received hydroxyurea, again, furthering the idea that maybe we are not doing our best. For the next couple of slides, I'm going to talk about sickle cell disease in terms of research and clinical trials. Farouk in 2020 published a study looking at disease-specific funding between sickle cell disease and cystic fibrosis and the association between the funding and research productivity. This was a cross-sectional study that reported metrics of disease funding and indicators of research productivity amongst 4 different groups, including the National Institute of Health, publications, foundations or universities, and industry-sponsored trials through clinicaltrials.gov. Cystic fibrosis is comparable to sickle cell disease as an inherited, progressive, life-threatening disease associated with decreased quality of life and shortened lifespan, but it also primarily affects white Americans. It is also an orphan disease. Cystic fibrosis affects 1/3 fewer Americans than sickle cell disease, but receives 7 to 11 times the research funding per patient, which results in disparities in the rates of development of medications. This particular study concluded that significantly more research articles and drug approvals were found for cystic fibrosis compared with sickle cell disease, but the total number of clinical trials were similar. And I think it's also a good time to note that even when coming up with the articles and trials for review for discussion today, many of them were also published maybe 5 to 10 years ago, and quite a few of them were position statements or commentary articles like letters to the editors or Ask the Doctor. The NIH allocates research funds in accordance to disease burden. So things like heart disease or cancer receive the largest amount of funding because they are associated with significant morbidity and mortality for millions of patients. Although sickle cell disease is 3 times as prevalent as cystic fibrosis, both diseases receive approximately equal NIH funding. Data from the clinicaltrials.gov website show that there have been more than twice as many industry-funded trials for cystic fibrosis compared with sickle cell disease. The authors attribute this to the Cystic Fibrosis Foundation venture philanthropy model that has helped produce breakthrough therapies for cystic fibrosis and allows for the investment of large sums of money in early stage drug development, which has contributed to novel receptor modulator therapies. As I mentioned before, because of the rate of disparity in funding, there has been greater advancements in medications for cystic fibrosis. In contrast, the few breakthroughs in sickle cell disease management occurred almost incidentally. In 1984, a patient with acute lymphoid leukemia and sickle cell disease underwent stem cell transplant, which also cured his sickle cell disease. That same year, hydroxyurea, once a chemotherapy agent, was found to increase fetal hemoglobin levels in sickle cell disease. However, hydroxyurea was not approved by the FDA until 1998 for the treatment of adults with severe sickle cell disease. A specific FDA indication for children was not obtained until 2017. The development of targeted therapies for cystic fibrosis within 25 years of discovering the genetic mechanism of the disease further accentuates the almost century-long drought in drug development for sickle cell disease. Because of the challenges in receiving adequate care and the stress associated with perceived racial stigma, many patients choose to avoid care altogether, further increasing the risk of life-threatening complications. And it's fair to say that a lot of these are intertwined with each other and affect each other. How poor care coordination due to insurance or accessibility or general lack of the number of specialists or specialist centers may cause patients to repeatedly visit emergency rooms for care, which then further potentiates clinicians' negative attitudes towards their patients, and therefore these clinicians may exhibit implicit bias and feed into the poor care coordination. Then the lack of funding and investment gets thrown in there when we consider how much research and drug development is occurring for sickle cell disease. So then the next question would be, how do we address these disparities? Our hospitals and clinics must be safe spaces for patients with sickle cell disease. Racism is deeply ingrained in our society and culture. It informs unconscious judgment and implicit biases, even in well-intentioned clinicians, that can negatively affect the evaluation and care of patients and can be exacerbated in stress-filled work environments. So one recommendation would be to reduce the structural racism of patients with sickle cell disease, implementing universal screenings for social determinants of health, reintroducing federal funding for comprehensive sickle cell disease centers, and analyze the effect of race and racism on federal research funding, possibly even to include a national surveillance program for extensive and accurate epidemiological research, and providing psychological support for patients with sickle cell disease and including their providers, such as their social workers, patient navigators, and psychologists. Another recommendation would be to dismantle institutional racism. So as we saw earlier, access to qualified healthcare is limited by a lack of providers with expertise in sickle cell disease, insufficient numbers of and funding for integrated comprehensive care programs for adults, and the stigmatization of pain relief for sickle cell disease. So developing a formal hospital-based reporting system for safety events and quality improvements to document and respond to racist behaviors, include patients and their advocates on anti-racism task force, institute sickle cell disease specific pain management protocols to reduce the time to opiate administrations, and to empower patients to safely report concerns about racism or inequity, and to treat these as urgently and important as we treat our other hospital safety events. And the final recommendation was to address interpersonal racism with patients and colleagues. All healthcare providers must be open-minded and self-aware as they care for patients and recognize their own implicit biases and making a conscious effort to treat patients equitably, regardless of their race. So speaking explicitly about race within and across medical teams with the focus on the experiences of patients with sickle cell disease, to develop partnerships with patients and to recognize that they have the ability to educate us as well. Implement mandatory annual racial and implicit bias training in a supportive environment, practice mindfulness and self-reflection in care. This next one, to stop using the word sickler, which I thought was also very important, because this term sickler is a word that has a lot of racist overtones and is often used ignorantly to describe and depersonalize patients with sickle cell disease. And finally, create safe spaces for all healthcare workers to discuss race and racism and to report events as they happen. The Department of Medicine with the Hematology and Oncology Division at the University of Florida College of Medicine is an example of a curriculum that increased internal medicine resident awareness of sickle cell disease. Firstly, their patients were allowed to be seen by resident-led teams, therefore exposing the residents to the sickle cell disease population. They then created a didactic lecture series comprising of a session on bias and its effect on healthcare, a compare and contrast session reviewing sickle cell disease and cystic fibrosis, prompting learners to think about demographics and how it may affect biases, a mock root cause analysis reviewing the death of a patient with sickle cell disease in which bias may have played a role, and an invited lecture on healthcare disparities and racism in medicine. The authors measured the effects of the curriculum using surveys before and after the program to gauge changes in attitudes and concerns towards patients with sickle cell disease, as well as changes in the degree of comfort of residents caring for their patients. The authors noted that the scarcity of seeing sickle cell patients contributed to the residents' ability to adequately care for the patients, and that resident comfort levels did increase after completion of their curriculum. However, the authors did note that their program lacked incorporation of patients in an outpatient setting and did not include the patient narrative or their patients' perspectives. Yes. So to end our presentation, I think similar to the program that I just mentioned, that these could be good programs to expose our students and our residents to as well. And that even talks like the one that we have tonight can help get the ball rolling. So to end, I'd like to end with a quote from one of our authors, Dr. Power Hayes, and writing an article in the New England Journal of Medicine. She wrote, "Change begins with a conversation, but words are not sufficient. We must take action to make enduring improvements in the care of patients with sickle cell disease." Our references, and thank you for listening to our presentation. At this time, we'll take some questions.
Great, thank you so much to both of you. It was a great presentation. So we have a couple of questions in our Q&A section. The first question is, how can we better treat sickle cell patients' pain within the recommended time frame?
So that's a really great question. One of the resources that we looked at, I would point to one of the articles in the emergency room slide. they looked at finding better ways to triage these patients. So maybe triaging them at like a higher triaging level so that we as healthcare providers get to them quicker and sooner. And one of the studies also looked at doing like an multidisciplinary team so that maybe if one person can't get to them, there are nurses, pharmacists, hematologists that would be able to get to the patients. So kind of
Great.
like having like a team-based approach.
Okay. The second question is, what resources are available to help care for sickle cell patients?
So there are some available resources out there. I believe the American Society of Hematology has published a few like webinars and lectures on better ways to care for patients. That was actually one of the things that they've implemented themselves on how to like promote sickle cell disease and make it more prevalent in their like for hematologists. And I definitely think that, you know, attending talks like the ones that we're doing tonight, and I noticed like a lot of our other chapters in the state are also starting to talk about sickle cell disease, which is great. I think, you know, being able to sit down together at the table and talk about, you know, what we're doing, and then what other institutions may be able to pick up from us or from each other.
And the last question is, are there support programs? Actually, there's more questions popping up, so that's a good thing. Are there support programs or communities we can recommend to sickle cell patients to join?
So I think for that one, I think it would depend on the site. I know for us here, I think we do have some support systems for our patients that we can refer them to. But I think a lot of, especially speaking like from our experience with our patient population, a lot of them find support with each other. And they find support actually through social media. A lot of them have like Facebook groups or, you know, emails, and they email each other about their, like how they're doing and like different treatments that they're trying. So I think also a lot of word of mouth. I think going back to one of the slides where we talked about, you know, patients advocating for themselves and empowering, you know, are empowering themselves to talk to us as providers. I think, you know, that is that's talking to one another is a good resource for them.
Okay. And another question is, do you know why or how cystic fibrosis used as the comparison versus other disease?
Yeah, so one of the reasons why sickle cell disease is often used is because sickle cell disease is it is like a life-threatening disease that decreases quality of life and shortens lifespan, similar to sickle cell disease. And they're also both orphan diseases. So it's kind of like sickle cell disease is for our African American patients versus the cystic fibrosis is for our white American patients. So, you know, being able to compare the two and see the disparities is very alarming and very prominent. So that's usually why, you know, we look at cystic fibrosis as the comparator. There's other, you know, you could potentially look at other orphan diseases, but the ones that most commonly used in the studies was cystic fibrosis.
Okay. And and also there's a support group in Buffalo, and the website is called www.scwbuffalo.org. Once again, there's a support group in Buffalo called, and the website URL is www.scwbuffalo.org. So being that we have no more questions from our attendees, the moment of truth here. All right, so now we're in our final hour of our DEI mini series, and the next presentation is called Compassionate Communication, a guide to embrace diversity, equity, and inclusion in the workplace by Dr. Amber Johnson. Dr. Amber Johnson is a senior pharmacist at the Rockefeller University in Manhattan, New York. Her current responsibilities include participating in the development of clinical research protocols related to the use of drugs, developing protocol-specific pharmacy policies and procedures, and preparing, compounding, and dispensing investigational drugs. Her experience in research spans 11 years, practicing as an investigational drug services pharmacist in health system and clinical research settings. Dr. Johnson is a graduate of Florida A&M University and completed her residency training at Beth Israel Medical Center. She's a board-certified sterile compounding pharmacist and holds a Master of Business Administration degree with an emphasis on healthcare management. Dr. Johnson has been a member of NYSCHP for 8 years, serving as the co-chair of the Mentoring Committee in 2016 and board of directors as treasurer from 2017 to 2021, and currently as the chair of the Diversity, Equity, Inclusion Committee for the New York City chapter. She is also a member of the American Society of Health System Pharmacists and served as a grant reviewer for Pharmacy Leadership Scholars in 2021 and 2022. I'd like to present to you Dr. Amber Johnson.
Good evening, everyone. Thank you so much, Sheree, for the great bio and the introduction. I'm happy to be here, and I thank the New York State Council for having me. As stated and shared here, my presentation is on compassionate communication, a guide to embrace diversity, equity, and inclusion in the workplace. Before beginning, I'd like to share that this is a space intended to be one that is respectful, inclusive, and free of judgment, for all of us to speak our minds and provide our own perspectives to increase the quality of the conversation. So with that, let's begin. I have no financial relationships to disclose. Tonight's objectives are to define and discuss DEI in the workplace, define and discuss compassionate communication, and apply strategies and tips for embracing DEI in communication at work. By the end of this session, you should be able to answer the following questions. 1, which is true regarding equity and our equality? 2, what are the 4 principles of compassionate communication? And 3, which option is not a tip that embraces DEI in communication at work? I like to start with a few polling questions to get you all involved and excited about our presentation. So the first, does your organization, let's see, I have this here. Does your organization, okay, I have to move it. Everything's coming up on my screen. Does your organization invest in or incorporate DEI initiatives or training? Yes or no? And this can be anything from establishing a DEI office or position, the creation of DEI surveys and focus groups, celebrate diverse holidays, targeted recruiting, or mentorship programs. So yes or no? Right? So let's see what those results say. Oh, wow, 77% of organizations has incorporated some form of DEI initiatives or training. So it's good to hear that. All right. So we'll go on to the next question. Do you participate in DEI initiatives or training? That could be at work, or it could be a part of another organization you may be a part of. Yes or no? All right, survey says 69%. All right, I'm happy to see that. All right. Next, how comfortable do you feel sharing your opinions at work, even if they differ from the group? So do you offer your opinions at work meetings? Do you speak up when you have a different perspective? And if you do, how comfortable do you feel? Are you very comfortable, somewhat comfortable, not too comfortable, or not comfortable at all? Interesting. All right, 32% is very comfortable, 50% somewhat comfortable, 18% not too comfortable. All right, so last question. What best describes your confidence in delivering culturally competent care? Culturally competent care is the ability to deliver healthcare services to patients with diverse values, beliefs, and behaviors that can meet social, cultural, and linguistic needs. Culturally competent care allows compassion, empathy, respect, and understanding. So, what describes your confidence in delivering that care? Are you very comfortable, somewhat comfortable, not too comfortable, not comfortable at all? Very comfortable, 33%, somewhat comfortable, 63%, not too comfortable, and 4%. All right, so this is good information. I created these poll questions because I wanted to provide some insight into your current DEI experience. And it's my hope that it can help you identify where you can focus more of your efforts. So what does DEI mean in the workplace? DEI in the workplace is the implementation of practices or policies that allows people of various backgrounds to feel welcome and ensure they have support to perform to the fullest of their abilities. To understand DEI in the workplace, one must first understand the meaning and significance of all the variables. So now I'll go into the definition of each one. Diversity is the makeup of the workforce. It consists of employees of different genders, race, religion, age, sexual orientation, or socioeconomic status. It could be others as well. Equity recognizes that each employee has different circumstances and needs, therefore requires different resources and opportunities to thrive. And on the next slide, I'll go into the difference between equity and equality. Inclusion encourages employees to voice their opinion, participate, and contribute to company success. Each variable is necessary to drive change at an individual and organizational level. And also, I want to say that DEI is not reserved for one group of people, it's for everyone. So it's a group effort, and it's really important for that to be for all of us to get along with each other and also to make sure that we are caring for our patients. So I came across this image online and thought it explained equity versus equality fairly well. The image shows two characters with the same book at the top. The character on the left is on Earth, and the character on the right is in space. So equality is providing the exact book to prepare fries, which is the top picture. Equity is providing the different books based on the location that will provide the same end result, which is the bottom, equity. So at the end of the day, every employee should be given an equal chance, not the same resources, to succeed. Now to compassionate communication. It's also known as nonviolent communication, and it was founded by psychologist Marshall Rosenberg. It's a tool designed to help us think, listen, and speak in ways that awaken compassion and generosity within ourselves and between each other. As healthcare providers, we have proficiencies in hard skills. We have degrees, we have licenses, we have certificates. But how are we exercising and improving on our soft skills? Soft skills are conflict resolution, communication, time management, problem solving. It's just as important and affects how well you work well with others, including your coworkers, as well as with patients. So that's why we're kind of diving in this today. Communication can be categorized as nonviolent or violent. Now, violence is a strong word to use, so I've been using compassionate communication for the most of the session. But if you want to define violent, it's a term used where it's defined as causing harm to ourselves and others. Violent communications, if you look to the left, is centered on judgment, evaluations, criticism, blame, and labeling, versus nonviolent communication, which is centered on observation, connection, and understanding. Think about a time you were offended. What was your immediate reaction? Oh, that person was rude. Oh, that person was a jerk. Oh, that person was this and that. You basically labeled someone else versus maybe trying to understand or observe to get to a point where you can be in a better space to communicate and understand that person. So the whole goal of compassionate communication is to connect with ourselves and others, to resolve differences, and increase harmony and understanding. There are 4 principles of compassionate communication. They are observations, feelings, needs, and requests. And I'll go into breaking down each one. Observations focus on what we are reacting to, concretely, specifically, and neutrally. It presents the simple facts. For instance, the statement to the left says, Ashley doesn't listen when I'm speaking. The statement on the left is a violent form of communication. It's very judgmental. The statement on the right, in our meeting today, I noticed that Ashley was on her phone. The statement on the right is a statement that is a simple observation. It is exactly what happened. And you reserve the judgment. Reserving judgment helps prevent triggering of defenses and opens up the possibility for an exchange that leads to understanding. So that's the main focus of observation, not identifying or labeling or shifting to something that's nonviolent, but actually stating exactly what is happening in that moment. Feelings. Feelings represent our emotional experience and physical sensations based on the observation. The statement on the left is, Ashley doesn't care about what I'm saying. It's a generalization about Ashley. The statements on the right, the first one, when Ashley is on her phone, I feel frustrated and concerned. The second statement says, I saw that you were on the phone during our meeting. Is everything okay? The first statement expresses your feelings and how you feel related to that moment. It doesn't generalize, it just states your feeling and expressing how you feel in that moment based off the observation. The second statement is another way to communicate passionately when you actually consider Ashley's feelings and needs. I saw that you were on the phone during the meeting. Is everything okay? So it's really just shifting kind of your, I guess I'm not saying shifting. This principle requires you to take responsibility for your feelings. And it requires a change in perspective of how others' words and actions affect our feeling. The feelings wheel. I don't know if anybody's ever seen the feelings wheel. I have seen it. I don't think I've ever used it. However, I'll explain in a little detail about what it is. The feelings wheel is when a person has a clear understanding of what they feel, they are able to address it more effectively. So the top half of the wheel identifies more negative emotions, and the bottom half identifies more positive emotions. So you see the first half in the middle, you see sad, mad, and scared. And then at the bottom 3 in the middle, you see peaceful, powerful, and joyful. From that, it is split into 6 colored triangles, and those are the ones that I've read. The 6 inner emotions represent the emotions that are easily identified with us. So we can easily identify being mad, being scared, being sad, being peaceful, powerful, and joyful. They're easy to identify, but it's usually secondary to what you're truly experiencing and feeling. The outer layers represent the primary emotion associated with each secondary emotion, which is that main emotion. Gaining insight into your true emotion helps develop more effective emotional expression. The better we are at identifying our emotions, the easier it is to control our responses, which would end up decreasing the negative ones and increasing the positive ones. Okay. Needs. Needs refers to our core values and deepest human longings. You see an example on the left, you see someone saying, I need you to listen at the meeting. That's what she's responding. I need you to listen. That's the response. The response on the left doesn't come across in the most effective way. The response to the right, where it says, it's important to me that our team participates and is present during our meetings. It shares the important and the reasons why, based off the feelings that she had. This is what the need is. This is why I need you to maybe not be on the phone. This is expressing why the need in that scenario. Understanding, naming, and connecting with our needs helps us improve relationships with ourselves and others, so we're more likely to take actions that meets everyone's need. Okay. Request. Request aims to identify and express an action that will serve the purpose, and then checks with others involved about the willingness to participate in meeting our needs in this way. So on the left, the request is, it would be great if you could pay attention at our next meeting. It's a bit aggressive. It comes off as rude versus the statement on the right, which is a more compassionate way to communicate. Can you put your phone away during our meetings? When you put everything together, you have this communication of where you have honesty and empathy, because the goal is to make the requests that are concrete and doable. And like I said, and get to a point where there's connection between the two people. So, and give a scenario. At a recent staff meeting, employees are asked to work in small groups when you, the pharmacy manager, overhears the following comment. In a minute, she's going to slap me like Will Smith. Sorry, I had to laugh myself. The presumed racial composition of the small group was 1 Black woman, 2 white women, and 1 man. The white man had directed this comment to the Black woman. You witnessed the employee who had previously been fully engaged withdraw from participating directly after the comment was made. How do you handle the situation? And this could be something, if you'd like to include in the chat, it's fine, but it's more of a self-reflection of what you would do. I wouldn't say there's the right or wrong to do it, but know what position you're in as well. You're a pharmacy manager. I know different scenarios of when you're in a situation where you see something, maybe not involving you, but as the pharmacy manager, what would you do? Would you ignore the situation, act like you didn't see it or hear it? Would you respond or maybe console the person that experienced the situation? Or would you respond and you talk to the person that actually made the statement? What would you do? I say, don't have to really necessarily say if you're not comfortable, but just think on that. Think on how you would handle the situation and what would be the way that you would respond that you feel is the most appropriate. As far as responding in a compassionate way, this is what would be the way to respond. During break, I pulled the person who made the disrespectful comment aside privately and navigated with the following 4 steps of the 4 principles. I heard you say this, which we all recall what was said about the Will Smith, and I observed Y's impact on the colleague checking out. As the pharmacy manager, I feel concerned because of my need to create an environment that allows all participant voices and perspectives to be heard and valued. Are you willing to be more thoughtful about your comments and interactions moving forward? So it's a dialogue where you approach it all the way. And also too, navigating conflict is never easy. It's never going to be something that feels great, but with practice and with time, it's something that you have to do and you have to navigate. So this is just one method. Compassionate communication is one method of going about addressing just hard scenarios and situations within the workplace that actually could be related to things that's involving diversity, equity, and inclusion. So, approaching compassionate communication, there's many ways. Self-awareness is one. Inclusive language is another. Observation without judgment. Discerning triggered emotions. Connecting emotions to needs. Making reasonable requests. So the first two was not related to compassionate communication as far as the 4 principles, but the last 4 are. Self-awareness is the conscious knowledge of one's own character, feelings, motives, and desires. When you are self-aware, you can objectively evaluate yourself, manage your emotions, align your behaviors with your values, and understand how others perceive you. Your behaviors and perspectives can be influenced by your cultural background, your religious background and beliefs, politics, and more. So with that, there's some definitions that I want you to kind of be aware of. Discrimination is person or a group of people that are treated unfairly or unequally. Discrimination can be through actions, comments, or harassment, and it's against the law and actually requires an annual training related to harassment for a lot of companies. So that's one thing that you should be aware of related to your being self-aware. Like, how are you related to discrimination? Are you discrimination? Do you feel that you play a part or a role in that? Implicit bias is another. It's the negative associations expressed automatically that people unknowingly hold and that affect our understanding, actions, and decisions. An easy way to identify some of your biases is to ask yourself what type of person you picture when you hear this. So just close your eyes. It's going to be like an exercise that we do. Close your eyes. Who do you think of when you hear the word doctor? Or who do you see? What person? What type of person? Do you see a white man? Who do you see? When you think of a janitor, who do you see? When you think of a police officer, who do you see? When you think of a drug addict, who do you see? So that plays into implicit biases, the association that you make related to people and what they do as far as their occupations. Also, another is microaggression. It's an insensitive statement, question, or assumption. For example, telling a person, oh, your English is great. Okay. Assuming a person with a disability needs help. It's an assumption. So it's a bit of a microaggression. Power and privilege is also other factors related to self-awareness as well. And the goal here is, like I said, with self-awareness is to be mindful of your biases, maybe microaggressions that play into it, and different ways that you can kind of maybe discriminate against others in the ways that you may not be knowledgeable or know. Tips: check in and examine your intentions. Like, when you really kind of think about what's in your mind, like, what is your goal? Is it to be kind? Is it to connect? What is your intentions when you say some of the things? Is it to joke? Is it to, what are your intentions? To really examine and kind of check in with yourself there. Be mindful about why and how you make decisions. Remain curious and humble about cultural differences as well. And with that, kind of wanted to pause and just insert related to the curiosity about cultural differences. I believe it's okay to ask some people from different cultures if they would be willing to share something with you related to those experiences. If they are okay with that and you ask in a way that you asked if they were willing to share, I think it's okay. But I also do feel it's great if you take the responsibility on the research on your own, because sometimes people from different cultures feel overwhelmed and burdened with being the go-to person. So just kind of be mindful and respectful on that, and do due diligence. Also, listen more than you talk. Being able to listen, actively listen, to kind of hear other people's perspectives outside of your own is important. Inclusive language is another approach to compassionate communication. Being mindful of the words that you say versus the words you should use. So instead of saying, do you have a boyfriend or girlfriend? Do you have a partner? Instead of using you guys are hilarious, you all are hilarious. I'm from the South, from Mississippi. We say y'all all the time. So y'all are hilarious, but just be mindful of making it where it's guys versus being inclusive of everyone. Are you from so-and-so versus where are you from? I actually had a situation, it wasn't at work, where I was away and twice was like, oh, we're from New York. Are you from the Bronx? And they said that twice. And well, two different people said it. And I just was like, I don't know how to take that. I don't know whether I don't know how to take it, because I don't know if it feels like a slight at the same time, but not really knowing the intention. So it could have been something that might have not been, malintent, but at the same time, it made me feel uncomfortable. So be mindful of the language that you use when you speak with people. It's important. Using the term ghetto, using the term bossy, saying like you sound this way. It's you just need to be mindful of the language that you use. So tips: be intentional and choose your words carefully. Avoid banter or inappropriate jokes. It could be something where it starts off as everything is funny and light, and then there could be something that's said and switched over and just kind of shuts down everything. So the goal is to avoid banter and keep it professional at most times, even if you feel comfortable with that person. And also apologize when necessary. We're not all going to be perfect. We're not going to not make mistakes. The goal is to apologize when you feel that you offended someone, or if someone has told you said that they've been offended. Like I said, no one is perfect. The goal is to kind of navigate this together and be in a space where you're connected. So the next four are centered on the four principles and tips related specifically to the four principles that we discussed, which were observations, feelings, needs, and request. So the first, observation without judgment. Present the facts observed. Don't add anything else to it. Just present what it was. Instead of saying someone is late all the time, so-and-so was late for 30 minutes on Monday and Tuesday. Just present the facts to avoid generalizations. Don't assume, don't just observe the facts, because you don't want to lead to judgment. Once you start thinking of ways where it's just negative communication, it just goes downhill from there. And also to recap conversations. If it's something where you're speaking with someone, or it's something where you observe it, repeat back what you see to agree, to make sure you're on the same page. kind of have a recap of the conversation to ensure you're both on the same page. That's important with recapping conversations related to observations without judgment. Next, related to feelings, discern triggered emotions. Be present. How are you feeling? Like when someone has said something, if you put your hands on your chest, you can feel you either getting upset, and you may just need to be present in that moment. And if you need to take a breather, take a breather. Walk away if you feel yourself upset. It's not okay for you to react just because your feelings are hurt and you're triggered. So if you need to take a moment, but come back, but also be able to express yourself and take responsibility for your feelings. Taking the responsibility for your feelings and expressing them is just a way to go about compassionate communication. Connect the emotions to your need. Build a vocabulary of needs. Do you need acceptance? Do you need respect? Do you need to be seen? Do you need to be heard? Build a vocabulary of what you need within those moments related to your feelings, and then be able to state those needs clearly. And like I said, this is something that takes time to build. It's not something, and with practice makes perfect. So with time, that's the goal, is for you to continuously working on that. But the goal is to be clear in your communication so the other person can understand what it is that you need as well. From there, make reasonable requests. Use positive language. Like I said, depending upon where you are within the request, you may not be able to get something that's doable. Depending on where you led from the observation to the feeling to the need, you may not be able to get the request or should be asking for it. But the goal is to use positive language, use language that is going to be able to have both needs be met. And be specific, again, as stated, with the needs. Be specific into what you're asking for or what you're requesting, and express what you want. We're wrapping up a little early, but we do have some self-assessment questions. So afterwards. So takeaways from this presentation. DEI promotes the present representation and participation of individuals who are different in a multitude of ways. Compassionate communication aims to fulfill our need to feel heard and listened to, and replaces defensiveness and aggressiveness with compassion and empathy. The goal of utilizing compassionate communication to embrace DEI in the workplace is to foster an environment where employees feel valued and respected. And lastly, I want to end with a quote before we start the self-assessment question. Diversity is about all of us and about us having to figure out how to walk through this world together. Jacqueline Whitson. So, self-assessment question. Which is true regarding equity and our equality? First, equity gives each person the same resources. Equality allocates the exact resources and opportunities needed to reach an equal outcome. 3, equity allocates the exact resources and opportunities needed to reach an equal outcome. Or lastly, A and B. Which one is true regarding equity and our equality? We all ready? Ooh. Oh, this is a mix. So it's 4% for the top 2. Then we have 32% with the 3, which is about equity. And then lastly, A and B. I think that was read wrong. So the answer, equity allocates the exact resources and opportunities needed to reach an equal outcome. But it gives each person the exact resources and opportunity. That's the difference. So it was a trick question. I like to do trick questions. So as we stated before, equality gives each person the same resources. It's about, like when we look at the picture at the top, one's on Earth, one is on space, and they have the same book. So that was equality. So the first one was wrong because equity is equality should give the person the same resources. So equality allocates the exact resources and opportunity needed to reach an equal outcome is wrong too. Which is B. Equality does not allocate the exact resources and opportunities. Equity allocates the exact resources and opportunities needed to reach an equal outcome. So that's why C is correct. Next, what are the 4 principles of compassionate communication? First, observation, needs, wants, desires. Second, observation, feelings, needs, requests. Observations, requests, feelings, wants. Are observations, emotions, wants, and requests? A, B, C, or D? Okay. All right. Ooh. All right. Well, the answer is B. So you had a mix of everything, but the 4 principles is observations. That's where you're looking at the observation and taking a visualization of what is the simple fact. The next one is feelings. What do you feel in those moments? And then needs from there is what do you feel or what is the need? And then requests. So B is the right answer. Last one. Which option is not a tip that embraces diversity, equity, and inclusion in communication at work? A, listen more than you talk. B, present the facts observed. 3, avoid banter or inappropriate jokes. Or 4, self-awareness. Okay. Ooh, child, y'all gotta mix it here. So this was also a trick question. So the question was, which option is not a tip? So the tips were on like the check mark. So the tips were to listen more than you talk, present the facts observed, and to avoid banter or inappropriate jokes. Self-awareness was a theme within that, but I also had tips underneath self-awareness. So that's why self-awareness was the option that was not a tip. So here are my references. I thank you all, and I am open for any questions that you have.
Thank you, Dr. Johnson. What a great presentation. So we do have some questions from our attendees. I'll go ahead and get started with the first one. So, of course, really great examples, Amber. For the scenario where the colleague made the comment, Lincoln Will Smith, what are your thoughts about addressing the colleague's comment in front of other colleagues?
I think, like I said, I don't think there's a wrong way. I think, like say you're in a meeting, and it really depends on the group of people. If it was public, then technically it was a public thing, and it would be okay to address in the public. However, it was in that moment where it's like, okay, let's explain to the person exactly what this is and make that a teaching moment so we can actually go to the person and she feel better. So it could be either way. It's not to say there's a right or wrong way. I believe that because it was in the meeting and it was said, it would be okay to address it in front of the colleagues because they were present. So it just really depends on, what you feel most comfortable with. But also too, at this scenario that I took from one of my references, they say that the end goal, exactly what happened, because it's actually really happened. The colleague went and apologized to the woman, and they saw a difference in her mood afterwards. So I think how it was set up, it was more of a focus group, and there were different groups, and they overheard it. But I do feel that if it's within a group, it's okay to kind of address it in front of the other colleagues because it was public. But it really just depends on how comfortable you feel and what you feel is the best related to you in the leadership position.
Thank you. Second question. Thanks for bringing up microaggressions. What are ways we can recognize and bring awareness to microaggressions?
That's a great question. I think being mindful of what it is. I think people aren't necessarily aware of maybe the definition, and maybe aren't just mindful. I think that's a part of just being self-aware, right? But I also think that really being aware of yourself and how you are, and how you act and things that you say, and being mindful of that is important. But it's also on colleagues to call someone out as well, because not self-awareness isn't about being open to to the view of yourself and what you feel about yourself, but what others feel as well. And I think us as colleagues, it's important for us to say, okay, well, you said this. It might not have been something that someone felt, but it's also too, some people may not even be comfortable communicating and speaking up for themselves. So sometimes other people need to be the advocate. So it's about doing the inner work. A part of it's how you identify the things that you say, take inventory, maybe keep a journal. It could just be a lot of different things, but I think a part of it is the self-awareness starts. And just being mindful of that, but also to calling out and just maybe, I say calling out, but actually addressing someone and actually bringing them to where it's like, oh, I think you said this, it maybe triggered something for me, and it maybe not trigger something for them, but it may be something where you want to go to them and actually say something and actually address that to where it's a possibility where they can actually communicate with that person and see exactly what that means to kind of be in a place where they can connect and understand each other.
Next question. What advice can you provide to those who would like to pursue holding effective communication about equity and equality?
What advice can you provide to those who would like to pursue holding effective communication about equity and equality? Great question again. For those who would like to pursue holding effective, I think, like I said, communication, especially related to compassionate communication about equity and equality, it's I think for DEI in general, a lot of people can kind of sit on the diversity end, but when you go into equity and inclusion, it's much harder. Like, how do you really implement that within the workspace? How do you make things equal? So I think more focus groups and more meetings are more necessary to see what that looks like, depending on what setting you're in. I think at the end of the day, it's to start a conversation. I think it's shying away from it. It's just, at the end of the day, it just doesn't help. It doesn't really help the cause. So I think being in spaces with people that may have the same, like say, whether it's a focus group or whether it's a passion, but kind of being in those spaces and actually starting the conversation is the first thing to do. Start it. And it's okay if you don't say the right words or have the right words. But when you go into it with the intent of trying to be better related to diversity, equity, and inclusion, it ultimately is going to get better before it gets worse. That's the goal. So that would be my That would be my advice.
Another question. I use the term guys generically and try to change to sometimes say folks. But is guys truly that demeaning?
Well, it depends on the person, right? I mean, I think the goal is to be inclusive. You never know who is going to be affected by it. You know, it depends. I think what's scary is like some people feel like, oh, you can't say anything. I can't say this, I can't use that. The goal is to just at least attempt to try. I don't, if you say guys and, no one says anything that's different, but to actually have an inclusive environment where, related to someone that may feel a way that never says it or speaks up with it, the goal is to just be inclusive. That's the way to have to be compassionate and to be inclusive. So I can't necessarily speak for everyone, but I think the goal is to, like I said, just be in a space where you're being much more inclusive. Saying guys or saying ladies, it's like, hey, ladies, say guys. It's different when you're just keeping it general and say, hey, everyone. It kind of would just make it a little bit more inclusive when you do that. Hey, everyone.
Okay. So this is regarding suggestions of creating a positive work environment. What are your suggestions to create equity versus equality? Reminds me of the golden rule, do unto others as you have done to you, versus the platinum rule, which is treat others the way they want to be treated. Sometimes it's not clear how they think or feel. What are your thoughts on that, Amber?
That's deep. To create equity versus equality. I mean, that's a deep question. To create equity versus equality. Well, within the workspace, I think it's just related to data. Like, for instance, if you have a group of employees and there's different like the metrics related to getting a promotion or get to a new position. Some people may not have those talents and skills to where they can kind of work their way up to succession planning related to the same resources. Say you have two people from two different backgrounds, and someone may not have that background of maybe formal training. Maybe they were able to work their way up to that position, but how do you make that equitable? How do you make that fair? Is it something where you provide workshops to both that's going to allow them to maybe put them in a position, and the workshop may be on different opportunities or different trainings. It's really kind of hard to say a suggestion, but I know the goal is to look at the metrics, look at the background, look at the data, and kind of see which ways you can go about to make it equitable, because also backgrounds and how people get to their positions are totally different. And I think that factors, resumes, all that matters as well, looking at that and seeing experiences that people come into. But the goal is to look at it, see what training, what background, and actually have a conversation about what the need is related to, say, a position, say, because we're talking about just in general about a promotion or getting to a new position. If at the end of the day, the goal is to make sure that everyone has a fair chance, is really tapping to what that looks like as far as those resources and the background that they have. And then from there, working up with metrics related to how they can get there to have a fair chance.
Hey, thank you, everyone. Oh, there's one last one. The person may want to be treated as a king or queen, so I would prefer to treat them as a fellow human being, not necessarily how they want you to treat them. It's just that person's thoughts, but what are your thoughts on that?
I'm sorry, say that again? The person may be one.
So the person may want to be treated as a king or queen, so I would prefer to treat them as a fellow human being, not necessarily how they want you to treat them. It's just this person's personal thoughts, but what are your thoughts and on that?
About kings and queens?
Well, some people may be treated as a king or a queen. So what this person is saying is I would prefer to treat them as a fellow human being, not necessarily how they want you to treat them. Like, what are your thoughts on that?
Okay. I think if someone tells you how they want to be treated, I think it's about mutual respect. I think in general, like I said, in general, when you're speaking to a group of people, at the end of the day, you want to be as inclusive with everyone. But if someone comes to you and say that they feel slighted or they feel a different way or a different opinion, then it's on you to kind of respect that if they feel a different way. But I think you should treat everyone as a human being. Everyone is. And the goal is to just be respectful. That's the whole point of compassionate communication. To be respectful, to not react, to have conversations in order to get both needs met in both ways. And that's the goal, to be able to work together, and at the end of the day, treat our patients in the most effective way as well, because it's not only about how we're treating each other, but it's about it's what we deliver for our patients as well. And all of that trickles onto that.
So thank you, everyone, for attending our mini series from last week as well as this week. Thank you very much, Dr.